So hello everyone. In this segment what we're going to be looking at is the ethics of clinical research. And we're going to be asking the question, what makes clinical research ethical? Now the history of the ethics of clinical research goes back to the Nuremberg trials of the Nazi doctors that happened at the end of World War II. And as a result of those trials, we had the first code of the ethics of research, the Nuremberg Code in 1947. And that was followed by the Declaration of Helsinki from the World Medical Association, initially in 1964. In the United States, we had the Belmont Report, and then the SIAMS Report, which came from Europe as well as internationally. And as you can see, many of these have followed over the years. Now, each of these was written in a particular historical context, typically to address questions that were going on at that time. And so they differ in a number of details, and indeed they conflict in some ways. So you do need to know which codes pertain to you and wherever you're doing your research. But for purposes of this talk, I'm going to not discuss any particular code, but rather speak more generally about the ethical issues that arise in conducting clinical trials. And to do that, I'm going to focus on this article that was published a few years ago in JAMA with authors from the National Institutes of Health entitled, What Makes Clinical Research Ethical? Now, one of the things I like about this paper is if you ask people what makes clinical research ethical, many times you'll hear one answer, informed consent. As long as you have the subject's informed consent, it's ethical. And what I want to show here is that it's actually more complicated than that. Informed consent is an important principle, but it's not the only one. And indeed, there's lots of ethical research that doesn't even require informed consent. So in this article, they cover 7 principles. That the research have social or scientific value, that there be scientific validity, fair subject selection, a favorable risk-benefit ratio, independent review, yes, informed consent is one of them, and respect for potential and enrolled subjects. So let's say just a few words about each of these. So value is important because enhancements of health or knowledge must be derived from the research. So ethical research is that which is designed to improve health or well-being. Examples of unethical research would include, say, those that are aimed at trivial advances in knowledge, like Me Too drug studies, for example, or research that might be too expensive to implement, or not generalizable to enough people. These are unethical because, first of all, we have limited resources. Money, of course, but it's not just money. There's biologicals like tissue specimens and even the volunteers themselves. And it would be unethical to expose human volunteers to harm without sufficient societal benefit. Second is scientific validity. The research must be methodologically rigorous. So as the SIAMS guidelines state, scientifically unsound research on human subjects is ipso facto unethical in that it may expose subjects to risks or inconvenience to no purpose. So for example, we know that statistical power is an important part of scientific validity. And in this regard, there was an interesting article published in Science a couple of years ago, which very surprisingly showed that 20% of trials at NCI cancer centers fail to accrue a single volunteer. And 60% of NCI trials are unable to meet minimal recruitment goals. So this is a real problem with scientific validity. I mean, you think about the hundreds and thousands of hours that go into developing these protocols, reviewing them, getting them approved, and then volunteers who agree to participate in these trials whose efforts there are wasted because these trials don't lead to any usable results. So scientific validity is an important ethical issue to keep in mind. Fair subject selection, which is a matter of justice. One aspect of this is that populations that bear the risks should also be eligible for the benefits. And this is an issue in the developing world where use of subjects in these parts of the world often are done to research medications that the developing world will never be able to afford. So they're really being used for the benefit of others, not ethical. In addition, the research subjects should match the expected population of use. It wasn't that long ago that all clinical research was done with men, because people were concerned about what the effects of new drugs might be on a woman who had a gestating fetus. But as a result, we ended up with a lot of medications where we don't know how they work in women. And so today, with appropriate protections, we do encourage that women be included in clinical trials. And now the same logic is extending to children. As a pediatrician, I can say that for the medications that we use in pediatrics, we know very little about them. And so now that when we know that medications can be safely used in adults, it's important that children be included in clinical trials. Fourth is a favorable risk-benefit ratio. That is, how we account for risks and benefits to patients and to society. And here I want to explain it to you in a way that differentiates between how we think about this ratio in clinical care versus clinical research. So in the context of clinical care, we think about patient benefit and patient risk. And when the benefits to the patient exceed the risks, this is something that we generally offer to the patient. But it differs with clinical research. So here, in many cases, it turns out that the risks to the subject exceed the benefits. So how do we get to a favorable ratio? Well, it is only by adding benefits to society onto this balance that we tip the scales in a favorable way. Now, if you think about it, there's a lot of research which has very little, if any, benefit for the subject. And so it is only the benefit to society that makes this ratio favorable. So examples would be placebo-controlled trials, pharmacokinetic studies on volunteers, some epidemiological research, most phase 1 research, as we'll be talking about in a later module. You need to think about the benefits to society in order to make this research ethical. 5 is independent review, or an outside perspective. Now, among many investigators, we hear them say that ethical review boards, or institutional review boards as they're called in the United States, are often seen as a hindrance to research. And this is really very much a misunderstanding. Without this independent review, you as investigator must balance the competing ethical considerations yourself and then be totally accountable for it. What independent review does is shifts the primary responsibility for this balancing to the IRB. And in this sense, it offers a tremendous amount of protection to investigators, which is something that's really important to remember. 6 is informed consent, how individuals should be informed about the research and provide their voluntary consent. And here there's really not much difference between clinical care and research. The principles are the same. Subjects should be accurately informed of the purpose, the methods, the risks, the benefits, and the alternatives to the research. They must understand this information and its bearing on their own clinical situation. And they must make a voluntary and an uncoerced decision about whether to participate. Finally, number 7 is respect for enrolled subjects. What we might say is going beyond the consent form. Here, important points are respecting privacy in the way that personal information is managed, respecting the rights of patients to change their minds and to withdraw from studies without penalty, monitoring their welfare, and recognizing their contribution by informing them about what was learned. Now, this is a relatively new way of thinking about things, and I think in general shows how we are shifting from seeing our volunteers as human research subjects rather to seeing them as human research participants and as partners as we move forward with advancing medical knowledge. So that's a little review of 7 principles. Let's go on now and talk about a couple of important misunderstandings and then go on and look at some areas of controversy. Now, all of this relates to really what is a fundamental ethical dilemma. in doing clinical research. It is as follows. The goal of research is to acquire generalizable knowledge to improve the health of future patients, whereas the goal of clinical care is to improve the health of our current patients. What happens when these goals conflict, as they almost always do in clinical research? A helpful way of looking at this is to think about two perspectives, the clinical perspective and the scientific perspective. The clinical perspective is that as doctors, we have an ethical obligation to provide patients with the best clinical care that we can offer, whereas from the scientific perspective, we have an ethical obligation to perform the highest quality research of which we are capable. And so these two different perspectives lead to some misunderstandings. So let me mention the two most important. Therapeutic research, the idea of therapeutic research, and what's been called the therapeutic misconception. So the concept of therapeutic research, this phrase, it's widely used in the way we talk about ethics, and yet it is mistaken. Fundamentally, it is an oxymoron in the sense that the phrase is internally inconsistent. If we knew what we were doing was therapeutic, then it wouldn't be research. It would be therapy. So use of this term is really a misguided effort to collapse the tension between the clinical and the scientific perspectives. And yet despite this, until recently, the concept has been embedded in many of our regulations, even the Declaration of Helsinki. Now all the more modern guidelines have dropped this term. The other misunderstanding that you need to be aware of is the therapeutic misconception, which is the false belief that the purpose of research is to benefit the patient. The purpose of research is always to benefit future patients. Now, it may be that a side effect of doing research is that the subjects are benefited, but that's a side effect. It's never the purpose of doing the research. And yet, confusion about this is widespread, as when patients will say something like, "My doctor wouldn't have recommended this study if she didn't think it would be good for me." And work by Paul Applebaum and others over the years have shown that this misconception is pervasive among not only subjects but also physicians and investigators. And people have felt that we really need to take bold steps to counter this misconception. So for example, Rebecca Dresser, who's a well-known bioethicist and health lawyer, has suggested that researchers must give patients stark, bold, and dramatic signs that research is different from clinical care. Instead of the white coats associated with medical care, investigators could wear red ones. Well, you can imagine, this would be a pretty radical solution, but I think it shows how seriously people take this and how some people feel we really need to work hard to dispel this misconception. All right, finally, let's look at different ways that this ethical dilemma plays out in the way that research is designed and conducted, with comparing the scientific perspective to the clinical perspective. And let's start first of all with the very design of the research and whether the comparisons are conceived of as the null hypothesis or in terms of clinical equipoise. So we know from the scientific perspective, we typically presume or prefer the null hypothesis. Statistical methods are based on rejecting the null hypothesis. And in lab experiments, when we work with mice or rats, we often expect to reject the null hypothesis. That's the way the experiment is designed. But you can't do this when you're working with human beings. You can't say, we have this drug that we're almost sure works really, really well, but we're going to do this experiment on humans just to prove that. You can't do that. And so we need a different construct, which is called clinical equipoise. And so our comparison groups need to be set up with the understanding that there is uncertainty within the professional community as a whole between these choices. In other words, from the patient's perspective, the choice really needs to be a toss-up because we can't be sure which arm is going to end up being superior, otherwise the research would not be ethical. And so this way of thinking about it is necessary to reconcile how we do research with clinical care. Second is whether we construct our trials as being placebo-controlled trials or equivalency trials or non-inferiority trials. this sort of thing. And again, it depends on your perspective. So from the scientific perspective, we tend to prefer the placebo-controlled trial. And the FDA, in fact, strongly prefers placebo-controlled trials, even when effective alternative therapies exist. And this is the heart of the registration pathway that the FDA requires. So at times we need to take the scientific perspective. However, from a clinical perspective, the clinical question is not whether the new drug is better than nothing. More often, from a clinical perspective, we want to know whether the new drug is as good as or better than the existing drugs. So which one of these we choose, the perspective we take, is going to depend a lot on the context. Next is how we balance questions of informed consent versus protection of subjects. From a scientific perspective, we tend to emphasize respect for autonomy. We believe that subjects should be able to freely choose the level of risk that is acceptable for them. As clinicians, though, we're more concerned about protecting subjects. Why? Because the therapeutic misconception can never be completely overcome. So we need to protect subjects from that. Subjects need to be protected from taking unreasonable risks. So all of this is an important role for the IRB to balance these two perspectives. Finally, this plays out in terms of how we think about benefits to society versus risks to subjects. So we want to always think about the benefit to the subject, the benefits to society, and the risks to the subject. But then we have to ask, what counts as a subject benefit? Well, there's health benefits, of course, but what about other things? Very often, subjects are paid, for example, to participate in research. So if we give the subjects money, can we count that as a benefit on these scales? How about assuring them of exclusive access to experimental treatments that would not be available outside of the trial, for example? Or how about access to free care, which is what patients receive if they're willing to go to the NIH Clinical Center and be part of clinical research? So all of these are areas of controversy within the field, and in each of these cases we have to ask, when do these so-called benefits that go beyond health benefits, when do they become coercive and therefore unethical? All right, so what we've covered here are 7 principles. We've talked about 2 misunderstandings, therapeutic research and the therapeutic misconception. And we've talked about 4 tensions that arise between the scientific perspective and the clinical perspective. So as we move through the course, we move through the various stages of clinical research, all of these will be relevant, but we'll be coming back and discussing more of them specifically in the context of phase 1 research and then research that involves randomization. Thank you very much for your time and attention.